Good evening, all. Thank you for joining us again today in this evening, Sunday. I am Dr. Rizin Kusop, the Secretary of ABS. Welcome to our free live streaming webinar brought to you by the Association of Private Practitioners Sabah, ABS. As usual, during the session, if you have any question, please write them down early rather than later so that our speaker today will be able to address them early also. Our speaker this evening is Dr. Liaw Yun Hao. Dr. Liaw graduated from National University of Ireland in 1995, obtained his MRCPCH or MRCP in Pediatric and Child Health in UK in 2005 and fellowship in Royal College Physician Edinburgh, UK in 2012. He has worked in Queen Elizabeth Hospital in 1996 prior to joining a private hospital in 2001. Dr. Liaw is now the consultant pediatrician in KPJ Sabah Specialist Center, Kota Kinabalu. The topic he will be delivering today is URTI cases in pediatrics, which is very relevant in view of the current pandemic. Ladies and gentlemen, Dr. Liaw Yun Hao.
Thank you, Dr. Rizin, for your kind introductions. Good evening, friends and colleagues. Um, Welcome to this evening live webinar in this Sunday evening. URTI cases in pediatrics. I suppose this is from the pediatric point of view, this is the bread and butter stuff. I think most of us deal with this sort of cases day in and day out. I'm actually working in primary plus the secondary healthcare. So I run a clinic in KBJ Sabah and also doing in hospital management of cases. So I have the luxury to see those cases presented to me right from the beginning, and also those complicated cases and those cases that perhaps you have seen and subsequently refer for further management. So this one evening, I would like to share with you some of the experiences that I have, and hopefully when we go through the cases, we can pick up certain pointers that will help us, in management of URTI cases in pediatrics. Okay. Okay. So just briefly going into the URTI in children, so I can summarize it in one slide. Yeah. So basically, it ranges from common cold, pharyngitis, tonsillitis, acute bacteria sinusitis, and acute otitis media. So basically, it's involvement of the upper respiratory tract that we usually know of. However, so this evening, what I'm going to do is I'm doing on the other way around. So just briefly discuss natural history of the URTI in children. I'll show you how we normally talk to parents because with the pandemic, I think most parents are very anxious if the child having symptoms, fever, cough, even rhinitis. So they will perhaps go to your clinic and ask for all this information, and then look at the patterns of pathogens and prescribing pattern and factors influencing the choice of antibiotics. And then we go through a series of cases. Hopefully we can learn something out of that. Okay, as we know, URTI in children representing 50% of all diseases in preschool children. So half of the preschool children usually will present with URTI symptoms. 30% of those between 5 and 12 years of age. So as they grow older, the cases will reduce. So this is very important. When I talk to parents, some of them actually will come to see us they said, how come my child so frequent getting sick, so as frequent as every month or every 2 months. Yeah, some of them will tell you every 4 weeks. Yeah, but once they go beyond 5 years of age, so generally the infections rate actually will come down to 30%. So you back down to the background of about 4 to 6 episodes, yeah, between 3 and 7 years of age. So this one is very important. When you talk to parents, you let them know as the child grow older, get into the school age, then the episodes of URTI actually reduce. However, 20% of children with respiratory infections develop complications. This is very important. Out of 5 kids come and see you URTI, one of them actually will develop complications. And up to 1 in 4 will come back and see you again. So reconsultation will be 24 to 25%, and 20% of them will develop complications. So I think it's for you and me and to develop the art how to differentiate when they come in, who are the ones that are at risk of complications. Yeah. And of course, we have been bombarded because we are in the private sector. So it has been said most of them actually receive inappropriate treatment with antibiotics. And of course, from the parents' point of view, they're actually using a lot of over-the-counter cough and cold medicines, which has been said that there was no evidence those medicines reduce the severity and frequency of coughs. So we're going to discuss this also. Okay, look at the frequency of URTI symptoms. This one I think is very, all of us know about this. Yeah, as you can see, the commonest symptoms that children will get: runny nose, cough, sore throat, and feel unwell. These are the 4 commonest symptoms that any child with URTIs will have. Then followed by did not sleep well, irritable, poor appetite, and fever. So you see, these are the symptoms that for a young parents, they'll be very concerned. And if you look at the age group, so the younger age group, the predominant symptoms is crying excessively, needed extra care. This is a study actually done in a community setting, in a home, at home base. So you can see this is it's a diary which this group of children they register, and then they look at those who have episodes of URTIs, what are the symptoms that they have. So if you look at the older age group, the older age group tend to have symptoms like cough, did not sleep well, poor appetite, they have a higher chances of fever, headache, and they can complain of headache for the older age group, whereas the younger age group, they complain less. And then muscle aches and pains, not interested in surroundings, and also unable to get out of bed. So these are the complaints that predominantly on the older age group. Okay, the natural history of acute URTIs in children, they are biphasic. So basically, first 3 days of illness, the symptoms are non-specific and they are systemic or otherwise known as constitutional symptoms. For example, fever, not sleeping well, irritable, feels unwell, not playing well, and headache. By day 4, then the localizing infections in the URT, the upper respiratory tract, appears. Like for example, runny nose, cough, sore throat, feels unwell, irritable. Yeah, so these are the symptoms that actually may last longer, from day 4 up until 2 weeks of the illness. So when you look at when the child presents, so it depends on whether they present the first 3 days or the second phase of the illness. Most of the patients come at day 1 or day 2. So after history and physical examination, I usually will reassure the mother or the parents, saying that this is still the early stage. So the child actually is having non-specific symptoms. And after examination, we cannot find any focus of infection. So basically, there's no reason of concern. So what they need to do is to treat the fever, keep the child comfortable, and make the child well hydrated and rest well. So this is the management from the first day to 3rd day of life of the illness. Then after day 4, then they come up with the symptoms, and then parents will actually can give some symptomatic medicine based on the symptoms appear. So it's very important. Yeah. Okay, we look at the next slide. This is the durations of symptoms. If you look at the old symptoms here, basically most of the symptoms actually will resolve within 7 days. Of course, some of them actually can carry on to a full 2 weeks. Yeah. So you can see all age group 4 to 6, 7 to 9, 13 to 12, all actually the median symptoms duration is 7 days. And some of them actually have a little bit more symptoms. For example, runny nose, cough in the older age group, yeah, 7 to 9 age group. So the duration of symptoms is important. As we know, runny nose, cough actually can last to 2 weeks. So if the child comes back at the second week still having cough, as long as it doesn't disturb sleep, so you can reassure the parents. The patterns of URTI among under 5 symptomatic children. So this is the presentations. So you can see over 50% of them actually can present with rhinitis, the common cold, followed by pharyngitis, close to 20%. And some of them actually can have complications such as pneumonia. Yeah, so you always need to look out for that. So if the child is having fever, cough, yeah, symptoms, you always look out for the complications to see whether they're actually having pneumonia, whether it's mild, moderate, or severe. Sometimes they have maybe just having mild pneumonia to start off with, so you can actually manage it as an outpatient with antibiotics. Otitis media and tonsillitis. Okay, looking at the patterns of viral pathogens. Okay, this is interesting. So as you can see here, 23.9% of the virus are due to rhinovirus. So because of the rhinitis, the common cold, so majority of them is due to rhinovirus. And of course, secondly, adenovirus, followed by parainfluenza type 3, Boca virus. Now you look at here, coronavirus. Actually, this coronavirus has been here all the while, but this is not the pandemic strain. So if you look at the respiratory panel, when we do a respiratory screen, for example, if there's a case of pneumonia, we want to know the pathogen, so we look for what are the possible causes. So coronavirus actually is already in the panel. Yeah. So these are the possible viral causes, yeah, causing the URTI among symptomatic children. So URTI are common in children below 5 years of age and predominantly caused by viruses. If you do have a blood test that require blood test, so usually you got some pointer, for example, elevated lymphocytes, normal neutrophils with normal CRP, most likely you are dealing with viral causes. Whereas raise in neutrophils and CRP are more likely to predict bacterial infections. Clinicians should suspect URTI caused by viral infection whenever the child presents with just simple runny nose, congestion, nasally, fever, and dry cough. So most of the time, initially it's viral infection. Use of antibiotics should be minimized in children with URTI symptoms since most of the symptoms disappear within a week. So usually what I told my mom saying that if the child is well in between fever and the symptoms resolving after day 3, day 4 of the illnesses, most likely you're dealing with viruses. But if the fever and the symptom doesn't resolve, no sign of improvement after day 4, then if the child actually is still not turned around, so it should come back and for further examination and may need further investigation. Okay, now we look at this one is a study by the CRC and Ministry of Health to look at the prescribing patterns and factors influencing the choice of antibiotics in URTIs in Malaysia. This one actually is done about 10 years ago. Yeah, looking at the prescribing pattern, what antibiotics we use for what incident, what cases, indication, for URTIs, both in private clinics and also the government clinics. So you can see the number of prescriptions prescribed for antibiotics for the URTI diagnosis. The commonest actually is acute tonsillitis, followed by acute bronchitis and acute otitis media. So you can see here for the non-specific URTI or URTI symptoms, more than 50% actually has been prescribed with antibiotics. And then there are certain percentage of them actually are given broad spectrum antibiotics. So the overall antibiotic prescription in URTIs, in the public clinic, government clinic, about 31%. In the private clinic, slightly more than double. Whereas the broad spectrum antibiotic prescribing in URTIs, so you can see here in the public clinics, very small percentage, 2.6%, whereas in the private clinic, 31%. So as you can see here, the overall antimicrobial prescription is high. This may be explained by factors. So you see, these are the things that actually will go through our minds when we're sitting in the clinic, in a private clinic, and then looking at the patients. So sometimes we have fear of untoward clinical outcomes. Yeah. So if you don't give antibiotics, so may come back with complications. Yeah. A desire to meet perceived patients' expectations or parental pressure. So we face that most of the time. Yeah. So some of the parents come to the clinic after the consultation, examination. So they will ask you, do my child need antibiotics? So of course, then they will ask, what if the fever doesn't settle? What if this? What if that? So they are actually pressurizing you. Should we start the child with antibiotics or not? Yeah. So you have to weigh the risk and the benefit. And of course, a certain area where there's lack of formal guidelines and believing that overprescribing on an individual may not significantly impact on the overall antimicrobial resistance. So the highest antibiotic prescription, as I mentioned, predominantly on the diagnosis of acute tonsillitis and bronchitis, which both predominantly are viral in origin. Okay. Also, broad spectrum agents prescribing in URTI is a cause of concern. Why? Because most of the time the narrow spectrum agents are recommended. Yeah, looking at the bacterial etiology. And here is the statistics. Most of the time, the younger, healthier adults and the older populations are more likely to receive antibiotics for URTI than children below 5. I think this one understandable. Yeah, conceivably, because the young adults want to work, working adults, so they want to get back to their workplace as soon as possible. And of course, for the elderly, they are more likely to get complications from respiratory infections. So it is understandable to start the antibiotics earlier than later should the complication arises. Again, they find out the overall and the broad spectrum antibiotic prescription is highly correlated with the method of payment. So for the private payment, usually they will get the prescription for the antibiotics. Yeah. Sometimes we actually may feel compelled to prescribe if they think the patients may expect that if you don't give, then some of them may not come back to you. Lower proportions of use of broad spectrum agents in the government clinics, mainly is because they have the very limited antibiotic option in the national drug formulary. So in conclusions, both the overall and the broad spectrum antibiotic prescribing are higher in private consultation than in public clinics. Yeah, these higher prescribing rates are associated with which type of URTI diagnosis, and also depends on the patient's age, the source of payment, ethnicity, etc. So there are many factors involving. Yeah, as I say, patient's expectation or parental pressure is one of them. Okay, so I am going to run through a few cases of URTI that you may all probably seen it very frequently in your practice. So and then some of them develop complications, and then see how we manage them. Okay, this is a 6-month-old boy. History of fever and cough for 3 days. So this is very classical fever and cough, 3 days. Presented to external emergency department on a Sunday morning, 7:20 a.m. So the history was the fever developed at 3 a.m. So after given the antipyrexia, the child developed very loud and noisy breathing at 5 a.m. And the history was the night before already attended the GP clinic visits and given nebulized bronchodilator twice, and subsequently discharged with oral antibiotics and oral medicine. So during the night, the condition worsened again. So they attend the external emergency. So on physical examinations by the medical officer, so obviously the child was respiratory distress, subcostal recession, inspiratory stridor, and have severe dyspnea. So the diagnosis at that time by the medical officer was severe dyspnea for investigation. So the chest X-ray was done. Both lung fields are clear. No abnormality detected. So repeat the nebulization. After nebulization, the child was cheerful and smiling again. So what is the diagnosis? This one is very common, especially at this age group, 6 months of age. So the diagnosis is croup. The important thing is the inspiratory stridor. This is not so much on wheezing. If it is wheezing, it's bronchiolitis. So bronchiolitis actually the involvement of the lower airway, the airway lower down. This one actually is more on the upper airway. Okay, so croup, otherwise also known as acute laryngeal tracheobronchitis. So it's at the upper airway, which is inflamed. Commonly, it's due to parainfluenza type 3 viruses. Especially children between 6 months to 6 years of age. But the highest incidence is around 18 months to 2 years. The basic pathology actually is the inflammation because of the viral infection causing inflammation at the mucosa, resulting in narrowing of the upper portions of the airway, and the child will have this what we call characteristic barking cough, usually worsen during the night when the room temperature drop, so they actually start coughing. My son had that before. So classically around 4 or 5 a.m. So they sit up and cough with the bouts of coughing, and sometimes the noisy breathing and the cough will actually scare the child because the barking cough it sounds horrible. So they are scared because of that sound, and most of them actually will have this what we call post-ptosis vomiting. So after coughing, then they will have a bout of vomiting. Okay, the differential diagnosis for acute stridor. So these are the standard textbook stuff. Okay, so the peak age for croup 1 to 2 years of age. Epiglottitis, we don't see that very often nowadays. Why? Because of the advent of the hip immunization. So we hardly see the Haemophilus. Usually this epiglottitis is due to the Haemophilus influenza type B bacteria. So we hardly see this anymore. Bacterial tracheitis, rarely we saw them. I've seen one before. This one, bacterial tracheitis, is very difficult to differentiate these two. But usually the bacterial tracheitis, the child actually is more sick. Usually with a fever, and this is a bacterial cause. I remember seeing one case came from Tenggilan, somewhere near Kota. So you see that what the mother did, the mother noted the child intermittently develops cyanosis and not breathing. So what so they actually seek for medical attention. So on the way down, until our clinic. So I saw the child. So when the child is alert, actually you don't see any abnormality there. Yeah, because the lungs actually is totally clear. The basic pathology is at the trachea. Yeah, but thankfully he actually developed an episode of this cyanosis and apnea. You can see the chest wall and also the abdominal indrawing, but then there's no air going in. Yeah, because the upper airway is just collapsed and shut down. So much so that we have to do immediate intubation. So we intubate, and then while intubate, we saw a lot of pus coming out from the trachea. So we need to do suction. So from the, you see, croup is a viral. You won't see any pus there, whereas bacteria is a bacterial pathogens. So you see pus coming out. Yeah. So the child actually will require temporary intubation for 1 or 2 days, get the infection under control, and then reduce the edema and the swelling. Yeah. Retropharyngeal abscess, rare, but can happen as well. Usually present with a neck swelling. Again, likewise, it's because of bacteria, so you got an abscess forming. This one actually is quite dangerous. Yeah, they usually present with painful swallowing and then with neck stiffness. Yeah, they cannot, they actually keep the neck in one position. They're afraid to actually turn on the other side. I remember when during the government service time, we saw one case during the handover. So we decided that child to be electively intubated. So the medical officer also sensed that this one is not an easy intubation. So she asked me whether I can stay back and stand by. So after we give the muscle relaxer and then want to intubate, we cannot see the airway. Yeah, because once you relax the muscle, so the abscess actually push the airway out from the center. So we have no visual. Luckily, the pediatric surgeon is on the way home, but before he reached the car, we actually managed to get hold of him. So what he did was he just did a bedside IND. Yeah, just do a bedside IND blindly, and the pus come out immediately. The airway actually on site, and then you can intubate. Yeah, so it's very dangerous. So luckily we intubate in the ICU, and this all happened in ICU. Yeah, so it's very dangerous to manage one if you cannot get the airway. Okay, so that's croup. So if you see one case like that, so you're basically what you need to do is to make the diagnosis of croup. You see, URTIs, there are no other investigation or like for example blood investigation or imaging to help you to make the diagnosis. Basically, this is clinical. Yeah, croup is a clinical diagnosis. So once you have a clinical diagnosis, then the next thing is you need to assess whether this child actually is the severity of the symptoms. Yeah, so there's a Wesley Croup severity score. So score on the level of consciousness, cyanosis, stridor, air entry, and retraction. Now, based on this severity score, then you can actually design how to manage this. So you score them less than 2, called mild, 3 to 7 moderate, 8 to 11 score severe, and of course different severity, the management is different. So for mild and moderate, they actually can be managed as an outpatient. Hospitalization may not generally needed. But for the severe one, like for example, frequent barking cough, stridor at rest, and also marked retractions, like the patient just now, yeah, significant distress and agitation, that one you probably need to give medication, and then you might need inpatient admission for monitoring, yeah, and to tie them over the acute phase. And then of course the worst one is the impending respiratory failure. This one actually, hopefully with the assessment of the severity score, the child doesn't progress until this stage, because this one usually you need ICU and you need ventilation. So for croup, If the child actually is very mild, yeah, only so you have to explain to the parents. Usually the symptoms can get worse during the night and early in the morning, but during the day the child actually is pretty comfortable. Usually they are well alert, conscious, playful, but then got this noisy breathing. So this noisy breathing sometimes can freak the parents out, so they feel uneasy, yeah. So you have to reassure them. See, as long as the child actually is well, the sound actually can last for sometimes even 10 days, 1 week to 10 days. So it's not immediately disappear. Of course, after a nap, it improves, but then later it will come back again. Okay, so you need to identify those high-risk individuals, like for example, 6 months and below. These are the high-risk group. So if they develop croup, you may need to actually refer for monitoring and observation. Others, like for example, previous episode of moderate to severe croup, yeah, so they have recurrence. So this one you may need to refer. For those who have medical conditions that predispose to respiratory failure, for example, neuromuscular disorder, chronic lung disease for those premature babies, Down syndrome, those with hypotonia. And of course, underlying airway abnormalities such as subglottic stenosis. These are the congenital abnormality of the airway, laryngotracheal Malaysia. So the action plan. So after discuss the severity and also the management, so parents should be advised to reattend their GP or hospital for reassessment if the child develops the following. For example, resting, inspiratory stridor, and the child is not active, also you have this stridor. But then sometimes when the child sleep, if they sleep soundly, you hear the stridor sound. But if it's not in distress, it should be all right. But if it's alert and then not active, is also having inspiratory stridor, then one you need to be alert and then look out for any retraction or inflowing on the lip, ribs, and the breastbone. Gradual quietening of stridor and decreasing retraction in a child who previously showed these signs and remain ill. Okay, this one is very important. If the child is well, active, yeah, and then stridor disappear, that's good. But if the child is not active and then is ill, the stridor, that means there is no air going in. If there's no air, then there's no sound. So actually it get worse. Yeah. So these are the cases they have to come back to the clinic or attend the accident emergency during the night immediately. Restlessness, agitations, and increased sleepiness. So tell them how to manage at home, observe and monitor. If progress, then they know what to do. Okay, when to refer to ENT if there's a recurrent episode. So for every case of croup diagnosed, you need to warn the parents. Most of the cases will have more than one episode. So in future, whenever they have URTIs, they might got a croup again. So you just tell them, yeah, this one may recur, but since you have the experience, you know what to do. Yeah. So you compare to this episode. If it's mild, by definition, if they get another episode when they are older, usually they are milder. The more it is more severe when the child is younger. Yeah. So recurrent episodes of severe croup or single episodes of croup requiring intubation. This one is a high risk one. So these are the ones that if it occurs, you need to refer. Recurrent episodes of croup without signs of coryza illness. This one need to look out for all those abnormality in the upper airway, unusually protracted clinical course, atypical age of presentation such as less than 6 months or more than 4 years of age. And of course, the cutaneous hemangiomata. Sometimes they have this upper airway or the vocal cord hemangioma. Okay, so that's the croup. We get it out of the way. Okay, next one. This is the 2-year, 2-month girl. Okay, this one is very interesting. It's a referral from Tawau. Okay, this child actually presented a year ago, February 2020, fever and URTI symptoms for 1 week. Yeah, GP visits and started oral antibiotics. Fever subsided after 6 days of antibiotics. So actually, started oral antibiotics at the early onset and managed to control the symptoms. But however, the fever not totally back to normal, still got low grade. So the parents actually a little bit anxious. So they attended the Tawau Hospital A&E and had a blood investigation done. And the investigation result is unremarkable. But problem starts again when the fever recurs 10 days after the illness. Very high, 39 degrees Celsius early morning. Noted swelling at the back of her right ear, tender and no ear discharge. Yeah, otoscopy done, narrow congested right external auditory canal. These are the lesions that are noted by the mother. So there's a swelling on the back of the ear on the right side, and then with high fever. So that's prompt them to brought the child to see a specialist. So the tympanic membrane noted to be intact. So on examination, the child was febrile, red and marked swelling behind the right ear and is fluctuant. So it's an abscess. So the impression that time was, is it lymphadenitis or is it mastoiditis? So the plan was to admit the child for IV antibiotics. The blood investigation showed raised inflammatory markers. Bedside ultrasound confirmed there's a liquefied right post-auricular abscess. So the ENT opinion was sought, and then a CT of the temporal and mastoid was done and reviewed a right mastoid abscess with extracranial extension and also complicated by dural sinus thrombosis. This one actually is a very rare. This is a cerebral sinus venous thrombosis, involving the right transverse and the right sigmoid sinuses. However, there are no focal neurological deficit, no neurological sign. So she was subsequently referred for ENT surgical intervention, and I was called to manage the thrombosis. So she was subsequently transferred from Tawau to our side. So the right ear EUA, myringotomy, and the IND for the retro-oral abscess was done on the 25th February 2020. Okay, for the management of her right transverse sinus and sigmoid sinus thrombosis, so we are using the Pediatric Anticoagulation Guidelines, CSVT, in children. So we are using the low molecular weight heparin instead of warfarin. So this one to be given every day and for a minimum of 3 months. So after 3 months, repeat the imaging again to assess for the recanalization. If the recanalization completed, then the anticoagulation therapy stopped. So she was discharged well with continual oral antibiotics and the enoxaparin injection. So the mother was taught how to give the sub-Q injection at home. So the child actually did very well. So this is a child with the otitis media, which has been actually given antibiotics right from the beginning. Initially thought to be reasonably controlled, but she still went on and developed complications of mastoiditis, and then with the extracranial abscess formation, and this is very rare with the cerebral sinus venous thrombosis that happens. So it's very rare, but it can happen, especially with the acute otitis media. So always look out for. So for us, if somebody presented with fever, earache, you always look for any ear discharge. Then of course you go back, look at the back of the ear, say any swelling, any redness, tenderness, or not. So this is the anatomy of the mastoid process, and also the middle ear cavity. Okay. So the swollen area, normally the sign is the ear is actually turned forward and is tender. If the abscess is there, it's fluctuant. This is just the anatomy of our the venous sinuses in the cerebral. So you got a sagittal sinus, superior sagittal sinus. The commonest actually is at the superior sagittal sinus for the sinus venous thrombosis. But the secondly is the transverse sinus, sigmoid sinus. So this girl actually is involving the transverse and the sigmoid sinus. So if you look at the CT scan, this one is at the, so as you know, the venous sinuses actually is follow the dura, the fox. Yeah. So this is the transverse and the sigmoid. So in the CT scan, actually you can visualize like this. So this is the right side, transverse and the sigmoid, which is enhanced with the contrast. Okay, acute otitis media, very straightforward. But one word of caution, you need to differentiate between what is acute otitis media and otitis media with effusion. Yeah, otitis media with effusion means there's a fluid collections in the medial air cavity, but there's no infection. Yeah, so this one, most of the authority, the ENT specialists, thought that this doesn't need antibiotics, whereas this one is an acute otitis media with a red, angry, and bulging tympanic membrane. This one will warrant antibiotics, and if the child will be in severe pain. So the important thing is to get the analgesia in to control the pain. Yeah, some of the cases may need laryngotomy, yeah, to release the pus. Okay, the management algorithm for acute otitis media. Later, I'm going to show you some of the algorithm that we have actually the URTI guidelines. We have guidelines from the ministry, also from the ENT faculty. So, which you can actually refer to. Yeah. So I'm not going to waste time. When to refer to ENT specialist: recurrent acute otitis media, persistent ear discharge, concern about mastocytitis or other complication like our case, perceived need for laryngotomy, abnormal audiology evaluation. Okay, next one, 12-year-old girl. Okay, this is very interesting. This girl just had her second COVID vaccination done a week ago. This is a very recent case. Okay, it started with a fever and sore throat. Throat is injected and red, and with a bit of strawberry tongue. Then it developed a skin rash over the body, the face, the limbs, and the palms. Yeah, it's itchy, dry, and then sandpaper-like. Yeah, the parents are a little bit paranoid, so they went for a swab test for COVID, which is negative, and the child actually is still having a rash and then with a sore throat. Yeah, so they came to see me. So I look at the child. For the 12-year-old, actually, I'm very concerned when they present with these symptoms. So after I examine, so you can see there, fever, sore throat, strawberry tongue, skin rash. This rash like sandpaper like. So when you look at this, this is in keeping with scarlet fever, isn't it? Yeah. So this is a scarlet fever. But you know, you need to think of there's a condition related to COVID. It's called MISC. Yeah, the multi-system inflammatory syndrome of children, of the childhood. Yeah, that one, the eye actually is not red. Yeah, her eye actually is not red, but then the tongue is red, the lips actually is red. So actually, I told the father, I said, so our diagnosis is scarlet fever. What is scarlet fever? Scarlet fever actually is a group A hemolytic strep throat infection. So that one need to be treated with antibiotics. This one, for those parents scared of antibiotics, this one you have no choice. You need to give antibiotics. The reason is to prevent complication. Yeah, scarlet fever, if not treated, they can develop complications like rheumatic fever and also the glomerulonephritis. So after explanation to them, and I did the hemodynamic check, it's stable, pulse rate 88 per minute, no tachycardia, blood pressure is okay, saturation is 95 to 96%. So I warned the parents. I said, okay, we need to start the child on antibiotics to eradicate this organism called group A beta hemolytic strep, because this is the one that causing the scarlet fever. Not all group A beta hemolytic strep pharyngitis will develop scarlet fever. Yeah, most of them actually with sore throat fever. Yeah, so you may need to make the diagnosis just by looking at the throat, the fever, the sore throat, yeah, without the rash. With the rash, with all the other sign is scarlet fever. Okay, for the assessment, strep score for group A, beta hemorrhagic strep pharyngitis. So there's a scoring system that actually can guide you. Like for example, if the child is having fever without cough, like this girl, fever without cough, and then with the sore throat, look at the tonsil, pharynx, any exudate, any lymph nodes and the neck, and then you look at the age group. If it's less than 15 plus 1 point, more than 45 minus 1 point. So after the scoring, so you can see if it is 1, 2, or 3, there's a possibility of 10 to 35% of strep infection. Yeah. If it is more than 4 or 5, more than 51% chance. So then you need to empirically start antibiotic. Yeah. So this scoring system actually can help us to guide whether to start the antibiotics early or without antibiotics, and afford to monitor and watch. So strep score, this is the algorithm. For more than three or more antimicrobial therapy, start antibiotic. If there is no history of a penicillin allergy, you can start in the penicillin group. If there's a penicillin allergy, you just start with the cephalosporin or the non-penicillin group. If it's less than 3, you can treat with analgesia, antipyretics, hydration, and then monitor the symptoms. Yeah. If it progresses, then you'll be assessed again. Okay, when to refer ENT specialist: recurrent acute tonsillitis, chronic tonsillitis, obstructive sleep apnea, unilateral tonsillar enlargement, complications of tonsillar pharyngitis. These are the implications to refer. Okay, sometimes the sore throat actually continue despite antibiotics. This one very frequent. Yeah, the child actually started on antibiotics after seeing the family doctors. So after 3 days of antibiotics, the sore throat is still there. So come to my clinic. So I ask the question, how bad is the sore throat? Just like beginning. Okay, is there any difference morning, afternoon, night? Is it pain only during the morning, then ease off during the day? No, it's equally throughout the day. Okay, so have a look. Can I have a look at the throat? If you look at throat, ulcer is there. Yeah, After's ulcer. So this ulcer, as long as the ulcer is there, the pain will be there. So it doesn't matter whether it's morning, afternoon, or night, whether you swallow fluid or solids. So sometimes you look at the, initially you probably won't see anything, but subsequently after 2 or 3 days, you look back again, the ulcer is there. So this is After's ulcer. Usually it's infectious ulcers. Symptomatic relief, and if you resolve within 1 week. Okay, then another case, 4.5-year-old girl. This one referred by her family doctor. Fever for 5 days, reduced oral intake, treated as acute pharyngitis. Okay, this one is very straightforward. Comments on oral antibiotics. High-grade fever, especially at night, despite antibiotics. Poor fluid intake. Okay, that the one thing that freaked the parents out was developed painful walking the following day. Yeah, tender calf, right more than left. Yeah, so brought the child back to the clinic. So the doctor saw, doctor refer, something is not right. Yeah, now we got a muscle ache. Yeah, and then poor fluid intake. So refer for admission and IV rehydration. So on examination, the child actually is having muscle aches. Yeah, so it's a myositis. So after admitted to the ward, blood investigation, mainly the viral in origin. Yeah, and then the lab co-op, this is the influenza type B. Yeah, so the child actually got influenza type B infections during that period of time, 2019, 2020. That's the time that actually we have almost like outbreak of influenza virus. So after rehydration and started on the oral antiviral oseltamivir, so the child improved and subsequently discharged. Yeah. So pharyngitis, sore throat after antibiotics, not resolving, and then with other symptoms, for example, myositis, muscle and ache, always think outside the box. Here are some of the clinical algorithms, diagnosis and treatment of respiratory illnesses in children. So this one actually you can Google Institute for Clinical Systems Improvement. You can actually Google it and then you can read about it. Yeah. So they go down and then for the viral URTIs, strep pharyngitis, non-infectious rhinitis, bacterial sinusitis. Okay, this one I just go through in the interest of time. Acute rhinosinusitis, this is the one that actually the symptom lasts very long. Yeah. So you see acute rhinosinusitis sometimes can be weeks, 2 weeks, 3 weeks. Yeah. So less than 4 weeks usually can be handled by primary care physician. Subacute rhinosinusitis may need to refer to ENT. Chronic rhinosinusitis need to refer to ENT. So usually this is a normal nasal cavity. This is acute. This is a chronic. And sometimes X-ray imaging need to be done to look at the fluids in the sinus. This is a management algorithm. Management algorithm again. Okay, so this is the last few cases. 5-year-old boy. Okay, this is the one that I think most of us will be seeing very frequent in this day and age. Low-grade fever, this boy, mild snuffles, nasal congestion, sleep reasonably well, appetite fair, on symptomatic medicine for common cold. So then I asked the mom, why actually you're bringing your boy to come and see me? So she asked a lot of questions. So then I asked her one question. I said, is there anything that you didn't tell me? You're hiding from me. Why? Because she asked a lot of questions. The child is very, symptoms-wise is very mild. Yeah. But then she's very concerned. So I said, is there anybody in the family or any family members having COVID symptoms? None. Okay. So I said, right, looking at this, as I mentioned, the first 3 days, non-specific, maybe just URTI symptoms. So go back, plenty of fluids, comfortable, rest well, take some vitamins if you want, yeah, and then monitor. 2 days later, the mother called back. The father actually was diagnosed swab COVID positive. I said, that day you didn't tell me. He said, no, I just went home. Then the father voluntarily disclosed a loss of smell and loss of taste. So the father went for the check. Okay, so I said, okay, since you are the close contact, so you and your son have to go for contact tracing. Need to go for a check. PCR. Don't do anything else but PCR. So 3 days later, she called back, crying. The son positive, but the mother is negative. I said, why are you crying? How's the child? How's the son? Okay, no more symptoms already. Yeah, I said, it's okay already. Yeah. So you see, for the child, even though they got the infection from the father, but then he's very lucky because the symptoms actually resolved. This is almost like a stage 1 or 2 symptoms only. Yeah, very minimal. Okay, this is another boy with a background history of autism spectrum disorder. Okay, this one also fever and cough, no respiratory distress, actually quite active and cooperative for physical examination. The mom actually volunteered the information. She suspected the father actually had the COVID infection. The reason is because the father actually has no smell, no taste, but he refused for checking. The reason is because he already doing home quarantine and he doesn't want to bother other people. So the mother cannot stand. So she took the child for the swab test. And then after finishing the swab test, she just, by the way, stopped by Dr. Liaw's clinic. So he ended up in my clinic, So I was like, oh no, I said the PCR will be positive. Yeah. So examination thought and nothing to see. The child is reasonably well. Pulse rate 99, saturation 98%. One of the reasons why the mom actually brought him to come and see me because she got the pulse oximeter at home, but then the son doesn't cooperative for checking. So she's cooperative in my clinic. So she asked me to go and check for her. So father was home quarantine, yeah, with lots of tests. Didn't check, but then the mom and the other kids had the test done, and then COVID PCR positive. So subsequently, actually, she did quite well after seeing me for another 2 days. Then the symptoms resolved and then back to normal. Yeah. So the mom, after he left, so we have to decontaminate the clinics for 1 hour or so. Yeah. So we have to close the clinic for cleaning and everything. So thanks to them. Then 2 weeks later, she called back. Is it okay for me to bring the son to come back and see you? I said, no need. If he's okay, he's okay. So after 2 months, I brought the child to come back and see me because he was attending the speech therapy. So it's very cooperative. And this time the mother gave me a task, help her to put the child on a mask. So I managed to put the mask on the child and then took the photograph. So he's a very pleasant boy. Okay, this is another one, 8-year-old girl. I think last one already. This girl with a congenital heart disease, surgical repair of VSD, coarctation, and PDA. Came to me day 1, history of low-grade fever, occasional cough with mucus, 37.3. Nothing to excited about. Mild heat rash at the back, no conjunctivitis, pulse rate within normal range, saturation 98%. However, had a history of henoch-Schwann purpura 2.5 years ago. So I asked all these questions. Nobody in the family has any symptoms, no contacts recently. So I said, okay, this is just a simple URTI. They already had a symptomatic medicine, so go back. I advise them after 3 days, if the symptoms not resolved or other symptoms, please come back. So after 3 days, they come back. Still febrile at home. In my clinic, only registered 37. Mild aches and pains over the left lower limb, yeah, associated with sore throat. Saturation okay, pulse rate is normal, no respiratory distress. So order a swab test, and lo and behold, yeah, COVID-19 detected. Again, we have to go and clean our room again, you know. So you see, this is only the mother and the daughter had a positive swab. The rest of the family actually is negative. So they were actually managed at home. So this child actually had stage 2. So managed at home, doesn't need to be admitted. So we actually notify, get the KKM to contact them. So eventually the symptoms improve and resolve at home. Doesn't need hospitalization. Okay, so I go back to this chart again. So basically, URTI is very common. It's our bread and butter stuff that we see every day. So actually, it's for us to learn the art, how to differentiate which one actually at risk of complication, because complication does occur despite giving antibiotics early. But we don't need to give antibiotics to everybody walk into the clinic with URTI symptoms. Yeah, so that's how actually to identify the high risk individual and to treat them well. So just as promised, to show you, this is a consensus guideline on upper respiratory tract infection, adopted by the Malaysian Society of Otolaryngologists, Head and Neck Surgeon. This is a very old CBG by the Ministry of Health, Management of Sore Throat, 2003. Prevention. Okay, so they will ask how to prevent. So nowadays, I think the parents can always come to us. Previously, about 10-20 years ago, they come to us and say, doctor, is there anything that I can do to make sure my child can get grade A in school? So they always ask about what is good for the brain. Nowadays, they don't ask that anymore. They ask, doctor, is there anything that I can do so that I don't need to see you so often? Not get infection, all these sort of things, Otherwise, then 6 to 8 episodes a year is very frequent. Yeah. So I usually tell them, see, I think this COVID already taught us a lot of lesson. So if you're PKP, your home control order, you stay at home, less exposure, then you got less infection. So actually, I think we know kan, yeah, during the PKP, I think the respiratory tract infections, all the infectious diseases actually came down remarkably. Yeah, even the hospitalization also come down remarkably. Yeah, so I think for infectious disease, the most important prevention is still hand washing, yeah, mask, and also social distancing. And of course, nowadays can the what do you call this nutrition industry also with this HMO, the human milk oligosaccharides, and also the probiotics to help to reduce improve the support the immune function and reduce the infections. For that, I thank you for your attention.
Thank
Sorry
you.
to rush.
Thank you, Dr. Liaw. Very informative talk. Okay, we don't have any question yet at the moment. We'll wait probably for 1 or 2 minutes. While waiting, I would like to ask you a question.
Yes.
This was highlighted previously in our talk when we were listening to URTI cases in adult. It's mainly related to cough syrup.
Yes.
What do you usually give to pediatric with URTI symptom for cough and flu, home remedy, I suppose?
Yes. For flu and cough, okay, so you see, it's like America. I think in the year 2005, yeah, not mistaken, year 2005 or 2010, I think across the globe, most of the institution, they ban the cough mixture, yeah, the flu and cough mixture for children. Initially it's less than 2 years of age. Now actually they extended to less than 5 years of age. Yeah, so that one is very important. Why? Because there were cases actually was given. You see, normally can whose fault is that? Normally it's the parents' fault. Yeah, but then we are the one that prescribe. So if we are the doctor that prescribe, and if the incidents happen at the child, so then if they go for litigation, then we are the one that responsible. You see, so that's why in America, the doctor doesn't prescribe, but the parents can bought it over the counter. Why? Because if the parents bought it over the counter, the responsibility is the parents. Yeah. So sometimes we are very careful. Like for example, my practice, yeah, sometimes the parents ask for it, yeah, because if the child cannot sleep during the night, so that the night disturbed, so then the parents sleep also disturbed, so they cannot function the following day. So they want something that actually can get the child to sleep well during the night. Yeah, so they want that. I usually for the very young infants, especially 6 months and below, I told them no. You see, if I write the script down, I write it for you to make you happy. By the time you reach the pharmacy, you'll bounce back. Say, Dr. Liaw, this one is not indicated at 6 months of age. Yeah. So I said that I cannot give you. So there's no medicine for that. But then nowadays, all the young parents and some of them actually with the reading, they're actually aware that, yeah. So I think at least for the first year of life, the flu and cough mixture is not indicated, especially for those sedated one. Yeah, sedation. I mean, for me, you have to be extra careful. You see, for me as a parent, I still remember, I shared with my parents as well, my patient's parents as well. I said that, my son was having severe nasal congestion and blocked nose, so cannot sleep. Okay, so then what I do is, not I do, my wife actually complained, so I said, you better get some medicine back, so okay. So I got the medicine back from the clinic. So I said, okay, how much to give? So I said 2.5 ml. Then I look at it, 2.5 macam get a kick and 5 ml. Never mind, I sleep with him. Well. So after 5 ml, I sleep soundly. The next day, he's okay, alive and kicking already. Yeah, because he slept well, rest well, and then he recover faster. Yeah, you see, I think all the working parents will know that, because their night disturbed. The child also disturbed. So sometimes they share with me, they say, with that illness drag a little bit longer. So if you give that, so I tell you have to be a bit careful. Why? Because strictly follow the instruction. If you accidentally overdose, that's your responsibility. So you have to caution them. Yeah, I mean, it is used judiciously, right time. I think it's useful. But if you use wrongly, then it become a poison already, isn't it? Yeah. So that's why it's important. You need to select. You need to select cases. So to answer your question, then you cannot generalize. You have to see that case by case basis, and then after that you prescribe. And then you also don't have to know how sensible the parents are. Yeah.
And of course, this applies to all the syrup medication, like from promethazine all the way
That's
to
right.
renewal,
Correct. Yes.
loratadine, desloratadine.
Nowadays, I mean, people try to get away with it is try to prescribe those non-sedative one. Yeah, and then for the bigger age group, we also know that those who are attending school or attending lectures, if you give them sedation, then they cannot focus, they cannot pay attention. So actually, it will affect their study. Yeah. So preferably actually using the non-sedative during the day. Yeah. That actually will help.
All right. I think there's a question here relevant to that as well, Dr. Saijan Samit. Your comment for cough mixture for those below 2-year-old, especially if the symptoms really disturbing,
Yeah.
Of course, from the books, they recommend also for home remedies, nebulizer and stuff. But
So usually for this, we do have parents like that. So initially we advise for topical, using topical agents, like for example nasal drops, sometimes mucus suctions, irrigations, something like that. And then of course control the room temperature a little bit, and then give a little bit of this um, you know herbal stuff. Some can you try to actually buy some time, so that actually they can get better. But after that, they still cannot. So they come back. Okay, so second, they revisit again, reconsult. Okay, so you have to give something else. So, okay, give something that is non-sedative. So you actually what you're trying to do actually is to try to help them, but then of course need to educate them at the same time. And then yes, some of them actually worse symptoms no choice they have to be given, but you have to caution the parents. Like for example, promethazine. I give promethazine.
I think the words is the caution the parents.
Caution the parents, because I give them. See, the parents actually know that I have this CP child, cerebral palsy with bad cough, disturb the child, feeding even. So I give the child was admitted for the pneumonia, so I give promethazine. Why? Because there's monitoring in the ward. Get on going home, I didn't give. Then the father come to me, doctor, I want that. Yeah, I said no. It only can be given in a ward and hospital. Yeah, because I said this one is important. If you accidentally overdose, it might have bad effect to your child. So I explain it to them. So sometimes they do so I make them understand that this is actually, it's not a knee-jerk reflex. You've got cough, you straight away you give. No, you have to try other things. But even you try, still no response, and then you already the symptom is quite disturbing. Then you give, and then you need to watch carefully. Yeah.
All right, thank you. Another question just came in. Muhammad Nazri Muhammad Daud. We have many choices of mucolytic available. Do you have any preference or choice?
Okay. I don't have a specific choice really. But usually you have to go with the patients, because I think it's like many other things. This one good for this patient, not necessarily good for the other patients. So sometimes you have to try and error. Once this one is working, then you stick to that one. Yeah. And then I always educate the parents, and most of these mucolytics, cough mixture, flu medicine, they are symptomatic medicine. Yeah. So I told them, my son, I maybe give 1 night, 2 nights. If the following night can sleep well, I don't give already. Yeah. Oh, you don't give until it get back totally resolved. No, no need. Because the purpose for me to give the medicine is so that he can sleep well at night. Once he can sleep well at night, I don't need to give already. So otherwise you give until there's no cough, no flu, maybe 2 bottles. Then your body every time 2 bottles, next time like drink water like that already. So it won't have effects already. So you have to shift to another one. So I told them, my son, cough mixture only one type, no any other type. So you just manage symptomatically. Once the symptoms resolve, then you stop it.
Okay, I think we finished the question. My last dying question is regarding COVID-19 for pediatric cases. Do you have any what do you call extra advices for all these GP who seeing all these URTI cases in pediatric regarding generally for COVID-19? I think one question is, do you actually test them for COVID-19 every single case?
No, you see, like for example, the cases that I have, you see, if they have symptoms for the first 3 days and they already come to your door, so they actually want your reassurance on it. But then you have to pick up which are the ones that require testing, which are the ones that doesn't require. So, like for example, after the history and then the examination, I have no reason to think that it's COVID. So I say, okay, this is just mainly URTI symptoms. Yeah, so it may or may not. And then if it's early stage, your test actually may be false negative. Yeah, so I say, okay, let's wait for 3 days. If the symptom resolve, that's okay. If symptom not resolving and it's still progressive or other symptoms pop up, then you come back, we examine, and then we check. So I did send for COVID test if it is a suspicious one. Yeah. So you have to pick. Don't because if you routinely everybody walk in and then you just do a test, when you got headache, when you got this false positive, what I'm going to do with that, false positive. I have cases like that also, false positive. We have one mother came in for delivery, yeah, emergency came in positive. So then the gynae called me. They go for section. I said, no, I'm not going to attend the Caesar. My nurse called me. I said, no, I'm not going to attend Caesar. Then the obstetrician called me. So he said, oh, this one, I think the CT level is 40 something, so it's not acute already, so like that. Okay lah. So then we have to press the special and then go in to attend that. Then the subsequent one, the PCR come back and it's negative. You see, so then we have to explain to the mother some more. I said like, no choice now. By definition, if it's elective, do PCR, most accurate. If you're doing emergency, sometimes you got false negative. False positive. That's what we want because we don't want to miss one. So if it's a false positive, then we are a little bit more cautious. So if I miss out one positive case, then we all kena so it's like that. So you have to explain to them. So that's why you have to be very careful on doing that. But then you have to protect yourself as well.
So mainly it's history.
History.
Asking whether possible contact.
That's right. Yeah. My clinic is still.
I don't think you can tell.
Cannot tell. So from history, we are still using appointment based. So from the history, making the appointment, we actually try to screen them.
Okay. In GP different.
Yeah. Especially if the patients are not your regular patients, then you ask extra questions if you're not your regular patients. If you're regular patients, okay, so like for example nebulizer, nebulization, because of the COVID, so nebulization is no longer used. So that's why, right, for example, croup, some of them they just give IM steroid. Yeah. Previously we actually can get away with budesonide in the nebulization form.
All right, thank you very much, Dr. Liaw. No more questions at the moment. I think we have come to the end of our webinar for today. Thank you all for participating. In a short while, we'll be displaying the QR code. Please scan the QR code for your CPD point. If you have troubles getting the point, please register your name as soon as possible at the link given earlier in the chat group. Thank you to our Secretariat, Ms. Melissa and Mr. Adrian, for their assistance. Thank you to our sponsor, KPJ Specialist Center Sabah. We'll see you again in 3 weeks' time. Thank you all. Take care.
Thank you.